Welcome to QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by Room Now Live. Meetings that matter, meetings that change thinking. That's what Room Now Live is, March 19th and 20th. Go to roomnow.live to register. Today's case is rheumatoid arthritis and eosinophilia. Hello? Those don't go together, do they? 51-year-old man presents to my clinic with a complaint of hands that are stiff and swollen. This has been going on in him for about 5 weeks, he says. And about 3 weeks ago, he had a fall and an open wound to his knee for which he received antibiotics. So that was sort of after the onset of his hand problem. He took the antibiotics, the knee is healed up, doesn't seem to be an issue going on right now. Currently, he has pain and stiffness, but really more stiffness in his hands, his arms, his shoulders, his knees, his legs. Shoulders, arms, and legs in a 51-year-old man. If he was 71, I'd be thinking PMR, except he's Hispanic. PMR is less common in Hispanics. It's predominantly a disease of older white folk, males and females. I have diagnosed PMR in a 51-year-old, but I probably anguished about the diagnosis and discarded it in maybe 200 others for the one I did diagnose. So it's possible. He has 6 hours of morning stiffness. He has fatigue. He has some numbness in his left arm. He doesn't sleep well because of pain. On exam, he has swollen joints, 9 of them, MCPs, PIPs, elbows, knees, cannot make a fist due to hand swelling, but yet his tender joints are only 4. It's a little bit like the last video we did talking about discordance between tender and swollen joints and what's the deal with the swollen joints more so than the tender joints. This one's not long-standing disease. This is a relatively new disease, 5 to 6 weeks. Right out of the gate, I diagnosed the man with rheumatoid arthritis. No lab seen. I give him 10 of prednisone a day, tell him to take that for 3 weeks, and then drop down to 5 milligrams of prednisone a day. I put him on Tylenol arthritis, 4 pills a day, and then, which is 650 acetaminophen, 2 BID, and I put him on 15 milligrams of methotrexate a week with daily folic acid. Would you wait for labs? I wouldn't, because what's going to change? You know, it could be weeks before I get my labs and make a decision. I'm treating him and look at the labs in a few days. And if I find a reason to stop, no foul, no harm, stop the methotrexate. Well, his CBC, CMP were all normal. He's got a little bit of anemia going on of chronic disease. He has a normal CBC, but his white count's normal at, I think it was like 6.0, but his eosinophil count is 713. His CRP is off the charts. It's over 6 milligrams per deciliter. SED rate's 87, rheumatoid factor 217, CCP greater than 250, normal LFTs, negative Hep B, negative Hep C screen. You know, what's going on? His primary care done a chest x-ray in him about a month ago, normal. And the question is this rheumatoid arthritis? And if so, what's the deal with the very high eosinophils? If you're around long enough in this business, you'll see rheumatoids with very high eosinophils. Go back in the literature and look at eosinophilia and rheumatoid, and you'll find a lot. Richard Panish wrote about this in 1970, I think, and Bob Winchester at Columbia did the same thing, and also in the 70s, where maybe the early thoughts was this happens uncommonly, and it may be associated with more severe disease and maybe with more extra-articular disease. And I think that there's a fair number of reports that sort of mirror that. But then when you start looking at larger numbers of reports on this, really elevated eosinophilia, especially if you're outside the United States, is frequently associated with parasites. And if that's at all a possibility, you got to work hard looking for, schistosomiasis, giardia, strongyloides, whatever. And it's a lot of stool O and P and whatnot. One series, from I think South America showed that all their cases were due to parasitosis. This particular series I got pulled up here from Emmanuel et al. In 2019, a study of 160 patients with RA. 19% had eosinophilia. That's 30 out of the 160. What were the causes? 6 of the patients, 30 patients had allergic diseases. Okay. 6 patients had bronchiectasis. 1 patient had hypereosinophilia of undetermined significance. Helminthiasis, parasites, was found in 21%. So eosinophilia, though, was unexplained in 56% of their patients. And they actually went on to give, because they're an endemic area, they went on to give them anti-helminthic therapy and showed some improvement. The point is that maybe as much as 5%, 7% of rheumatoids may have elevated eosinophils. I think the algorithm one must go through is to inquire about parasites and that possibility, foreign travel, etc. Being on the lookout for more severe disease and extra-articular manifestations. And then following that, and does it respond? Usually, as the RA patient responds, their eosinophilia usually goes down when it's all due to RA. This has been my experience. What's your experience with eosinophils and RA? Let me know. Tune in tomorrow for another QD Clinic.